Hi everyone, I'm going to talk about diabetes for a little bit, and I'm going to try to move through this as quickly as I can. There's a fair bit of content, but we did it all in class, so this is really just a review. We know that when we're talking about diabetes, there's two different processes that can happen either individually or in combination. One is where we have a process where there's a lack of insulin production that happens as we have the destruction of those islet cells in our pancreas. And second, that's type 1 diabetes. And secondly, we have that insulin utilization that becomes impaired. So we have, our pancreas is still able to make insulin. We have circulating insulin, but we're insulin resistant. So our body is not able to use that insulin effectively. And sometimes now we have mixed diabetes where we have both. And ultimately, we're moving to a classification system that has many different kinds of diabetes classifications. And we'll see over the next few years that will become refined. What we know is, regardless of how we're classifying it, diabetes is a worldwide health challenge with about 34 million people experiencing it. And what we're seeing is that within the next decade or so, that number will increase tenfold to over 350 million people. So important to keep in mind that not only do they suffer the consequences specifically of having high blood sugar, low blood sugar, but there's associated heart disease issues, right? Remember we talked about that in our cardiac class. Somewhere between 65 and 80% of people with diabetes die as a result of heart disease or stroke. And it's a contributing factor to deaths of more than 41,000 Canadians every single year. And important to recognize that Canadians with diabetes are twice as likely to die prematurely as people without diabetes. So this is a really significant health concern. Important to recognize that there are theories that try to explain the factors associated with the development of diabetes, but we don't have that complete evidence. Ultimately, what we believe is that there is a genetic predisposition and some kind of exposure to viral infection or an environmental exposure that leads to an autoimmune process by which your body starts attacking itself, and in this way it is related to destruction in large part of those islet cells when we're talking about type 1 diabetes. Important to remember, so the basic function of insulin is that glucose transport from the bloodstream across our cell membrane, and that regardless of the cause of that, diabetes is primarily a disorder of glucose metabolism, right? So that's related to or absent or insufficient insulin supply. Remember we just talked about that? So we don't have enough insulin, and or poor utilization. We're not able to utilize the insulin. So while there's many different types, we know typically we still talk about type 1 and type 2, and that's what I would expect you to see sometimes on your NCLEX, but the other ones we'll talk about as well. Type 1 diabetes, that results from that progressive destruction of those pancreatic beta cells, and that's typically an autoimmune process that we think is happening, and the antibodies of those islet cells cause a reduction of 80 to 90% of normal beta cell function before we see that hyperglycemia and other things. So a significant amount of damage occurs before we even see those symptoms. So again, we think it's that genetic predisposition and exposure to potentially a virus or something in the environment that creates this pathogenesis that we see in the type 1 process. Now, sometimes we do see some other processes caused by non-immune factors. But they're not as significant, and I'm not going to really pay attention to it right now. Important, though, to recognize that we see this impaired glucose tolerance, IGT, or impaired fasting glucose, IFG. And what we see there is that we've got a fasting glucose that is between, excuse me, 6.1 and 6.9. And so often we call that pre-diabetes. So we've got about 6 million Canadians walking around with pre-diabetes, and that puts them at risk for developing diabetes and its complications later on, particularly, again, cardiovascular disease. So about 50% of Canadians who have that prediabetes, remember that blood sugar between 6.1 and 6.9, about 50% of them will go on to develop type 2 diabetes in their lifetime. So and when we think about type 2, I'm trying to break that down. Typically we think of 4 metabolic abnormalities that play a role in the development of that diabetes. So the first factor is that insulin resistance. So that insulin resistance is in glucose metabolism and lipid metabolism. And so that's a condition where our body tissues don't respond to the action of insulin. We've got insulin, but our body tissues don't respond to the action of it. And that's because the insulin receptors have become unresponsive to the insulin, to the action of that insulin. And so we can have that there's an insufficient number of insulin receptors, or we can just have both things, an insufficient number and also unresponsive. Most of those insulin receptors are located on our muscles, on our fat, and in our liver cells. And so important to recognize that also when we think about how insulin mediates glucose uptake into the fat tissue, and our skeletal muscle insulin resistance in fat cells is also associated with a decrease in the number of cells that are responsible for transporting transporting glucose. When we have this condition and insulin is not being properly used by our body, the entry of glucose into the cell is impeded, right? So we've got glucose. We want that glucose to go into the cell in order for the cell to have fuel for its metabolism, for its activities. But when we have that resistance, that insulin resistance, that glucose is not able to be transferred into the cell, not able to be transported into the cell. And so as a result, we have hyperglycemia because we have too much glucose circulating and not enough at the cellular level. And in the early stages of that insulin resistance, the pancreas responds by just churning out more and more and more insulin to try to fix the problem. And that creates that sort of temporary phenomena of hyperinsulinemia. We have too much insulin. The problem, we're not able to use that insulin. Either we have insufficient number of receptors or those receptors are no longer working. A second factor in the development of type 2 diabetes is a decrease in the ability of the pancreas to produce insulin. The pancreas has worked and worked and worked and churned out, and the pancreas gets worn out. So we go from that initial hyperinsulinemia to the pancreas not being able to produce enough insulin. A third factor is an inappropriate glucose production by the liver. So instead of properly regulating the release of glucose in response to those blood levels, there's an increased secretion of glucagon from the alpha cells of the pancreas. That then stimulates glucose production from the liver, and that increases the blood sugar. Now, it's important to recognize this is well documented, but it's not considered to be a primary process, but it is for sure well documented. And finally, a fourth factor is the alteration in the production of hormones and cytokines by adipose or fat tissue, and as well as, again, not a primary problem. Other types of diabetes that we want to pay attention to, gestational diabetes, and some of you may have experienced caring for patients with gestational diabetes when you were in your MAP child rotation, diabetes that occurs within the context of pregnancy. The cure for gestational diabetes is delivery of the infant. There's a 50% chance that that person will go on to become diabetic later in life, so they're predisposed to that. We talked about, and gestational diabetes, the goal is to manage it nutritionally if we can during pregnancy, or you may have to move to some insulin use. We want to watch the size of the fetus, because with high levels of glucose circulating in our blood, the baby can grow physiologically large while not physiologically developed. So very big, but still their lungs aren't developed, the brain isn't developed, cardiac system may not be developed. So even though you have a baby that may be 7 or 8 pounds, they still may be physiologically at a 28-week stage. So important that we watch a patient who has gestational diabetes and their fetus well throughout their pregnancy. Prediabetes we talked about, 6.1 to 6.9. Secondary diabetes is diabetes that occurs as a response to other pathological phenomena, pathological conditions. Oh my gosh, let's talk about insulin for a moment. Insulin is a pretty exciting phenomena because it's so central, or the insulin production, insulin use, because it's so central to life, right? All of our life processes require glucose in order to have the energy to carry on with their functioning, and insulin is required in order to move that glucose into the cell. So insulin is produced by those beta cells in our pancreas, within the islets of Langerhans, and current theories, again, we talked about that, link the causes of diabetes to genetic, autoimmune, viral, environmental factors, and again, basic process is one of disorder of glucose metabolism, so that we have that insulin, which would normally be circulating continuously, and changes depending on the amount of food or the amount of food we eat, with a stable glucose range of 4 to 6 millimoles per liter. But when we have either type 1 or type 2 diabetes, we either are not able to produce insulin, or we are able to produce insulin, but our body is not able to effectively use it. So insulin, what is that? It's a hormone. We know it's produced by those beta cells in the islets of Langerhans, and under normal conditions, insulin is continuously released into the bloodstream in those small little pulsatile increments, and that's why we've moved more efficiently to using continuous insulin, as opposed to in the past where we used to inject insulin several times a day. We find that there is a much better control of diabetes for patients who are able to use a pump effectively. So what insulin does, we talked about that already. The activity of insulin is to lower blood glucose and to facilitate those stable, normal blood glucose levels in the 4 to 6 range. Other hormones have an effect. So glucagon, things like growth hormone or cortisol, which is the stress hormone, those work in opposite to insulin. And so we often call those counter-regulatory hormones. We talked already about skeletal muscle and adipose tissue, and those are tissues that require that insulin. So those tissues require that for either storage of glucose into fat, or taking glucose, entering the skeletal muscle cells, having it enter the skeletal muscle cells to be used as energy for activity. Other tissues do not directly depend on insulin for glucose transportation. That includes our brain, our liver, and our blood. So here we're going to look at type 1 diabetes and type 2 diabetes. Type 1 diabetes, we see there's that autoimmune process, destruction of those beta cells, and it can take a long time before we see clinical symptoms. There could be that sort of stuttering process of periods of increased thirst, increased hunger, and increased urination, followed by a return to normal. And then finally, those symptoms persist. And ultimately, remember, we're talking type 1, you know it, insufficient production of insulin. Type 2, it's a little bit more of a complex process. What we see is several things happening at different parts of our body. So we can have those beta cells can be defective, and that can impact the secretion of insulin. We also have insulin resistance. And so when we have insulin resistance through our body, that causes our pancreas to increase its production of insulin. So it churns out more and more insulin because our body is not able to use the insulin. The receptors are not able to make use of it. Eventually, we exhaust our pancreas, and so we have no more insulin. Our pancreas has just been used up. Within our liver, we can have excess glucose production, and also that inappropriate regulation of glucose. At the level of our adipose or fat tissue, we've got some hormones that are involved, leptin in particular, and that changes the way that we metabolize glucose and fat. And finally, at the level of our muscles, like those defective insulin receptors that create that insulin resistance. Now, we used to call type 1 diabetes juvenile onset or insulin-dependent diabetes, but and that was because of the age of onset, and we've now moved to type 1 and type 2. Most often still type 1 occurs in people younger than 30, although we now see that type 2 can occur in young children as well. Type 1, though, does occur more frequently in young children. So let's talk about the process of type 1 diabetes. The end result, it ultimately is the end result of that long-standing hidden process, progressive destruction of those pancreatic beta cells, that autoantibodies cause a reduction of 80 to 90% in beta cell function before we see those symptoms. We've talked about this already: genetic predisposition, exposure to a virus, or environmental things. There is a very long preclinical period that we tend to only be able to identify in retrospect. Antibodies can be present for months or even years before we start to see the symptoms. But then once we start to see the symptoms, that's when the pancreas cannot produce any more insulin. They are rapid, and often patients will present in the emergency department with ketoacidosis. And so we always watch for a recent history of sudden weight loss, and that those classic symptoms of polydipsia, which is excessive thirst, polyuria, frequent urination, and polyphagia, which is excessive hunger. When we're looking at clinical manifestations, we want to look at those three things we just talked about: polyuria, polydipsia, polyphagia, that weight loss, weakness, and really indescribable fatigue. When somebody develops type 1 diabetes, remember that their pancreas, we have disruption of those cells in their pancreas, they're not able to produce insulin, so they will require exogenous insulin to sustain life. When a patient is presenting with a lack of innate insulin, so they're not making any insulin and they're not getting any insulin yet, either they're not yet diagnosed or they have not been taking their insulin for some reason, they can go into a state of diabetic ketoacidosis. So that occurs, diabetic ketoacidosis occurs in the absence of that exogenous insulin. Diabetic ketoacidosis is a life-threatening condition in which your body moves from using glucose for metabolism to breaking down fat for metabolism. And a byproduct of that breakdown of fat is the production of ketone bodies. Ketone bodies circulating in our bloodstream change our pH and lead to an acidotic, a metabolic acidosis condition. And ultimately that is life-threatening, presents with profound dehydration, typically an associated tachycardia. You may have a hypotension or a postural hypotension, and the treatment involves rehydration and correction of blood sugar. Let's talk about type 2 diabetes for a second. Type 2 diabetes is more prevalent, even here in Canada, although type 1 diabetes and type 2 diabetes are on the rise. More than 90% of people that we see have type 2 diabetes. Usually occurs in people over 35 years of age, although we have diagnoses as young as 5 and 5, 7, 8. And most of the clients who develop type 2 diabetes, 80 to 90%, are overweight. So we know that the prevalence increases with age. There's a genetic basis, so it tends to run in families. And it's also associated with high-risk populations. So again, we have this genetic component. So we see indigenous communities have a higher propensity. Hispanic, South Asian, Asian, or African people have a higher propensity for the development of type 2 diabetes. So in type 2 diabetes, we're looking at a process where the pancreas continues to produce some insulin. And either, do you remember that either the insulin that produced is insufficient, not enough insulin, or those receptor sites are not able to adequately utilize the insulin. So what insulin we have is not able to get into the cells. One of the conditions that's really significantly associated with this is obesity, and in particular, that development of abdominal obesity. So often one of the measures we do when we're looking at insulin resistance is that abdominal girth and looking at the risk factors associated with that. We also understand that there's a genetic component to this. genetic mutations that can lead to increased risk for obesity and increased risk for insulin resistance. So when we think about the metabolic abnormalities associated with type 2 diabetes, we have the first one, and we've talked about this already, insulin resistance. Body tissues don't respond to insulin. I'm not going to go over that. We've talked about it. But it results in hyperglycemia. We've got insulin, we've got glucose. The body is not able to use that insulin to have that glucose go into the cells, so we have too much circulating glucose. In the second, the second abnormality is where then our pancreas has a decreased ability to produce insulin. So they just, remember, pancreas churning out, churning out, churning out. We initially have hyperglycemia as that insulin resistance affects our ability to use the glucose. Our beta cells become overwhelmed. They are used up and are destroyed. And so we end up with our pancreas that is unable to produce adequate amounts of insulin. The third process is that we have our liver involved. We have that inappropriate glucose production from our liver, which is typically responsible for regulating release of glucose, and instead it becomes quite haphazard. Although again, remember we talked about that's not a primary cause. And then finally, an alteration in the production of various hormones that play a role in fat and glucose metabolism. They list two. Leptin tends to be one that is talked about more often these days, but also adiponectin. So let's carry on with this. We talk about metabolic syndrome. They used to call that syndrome X when they were first talking about it in the 90s, and have now moved to talk about it as metabolic syndrome, which is that at its core, a cluster of abnormalities with insulin resistance, and typically that increased abdominal girth. But those characteristics leave a person at high risk for developing type 2 diabetes. Individuals with metabolic syndrome also typically are seen to have a high blood pressure, high lipids, that insulin resistance, which is a primary characteristic, and the blood sugars that are not regulated well. Risk factors for metabolic syndrome are that abdominal obesity, having a sedentary lifestyle. This is all sounding worrisome for me, isn't it? Living in cities, and part of that is associated with lifestyle. And again, we talked about genetic components, so certain ethnicities. With type 2 diabetes, we see a gradual onset versus that type 1 diabetes may take years to develop, but the onset of symptoms can be very rapid. Once that process starts, it's very rapid. With type 2 diabetes, we often see a very gradual onset, and patients can go many years without even being diagnosed. Instead of developing diabetic ketoacidosis, for patients with type 2 diabetes, often what we see is this osmotic fluid or electrolyte loss. So as they have this high blood sugar and higher blood sugar, but not in the very, very high range, and it occurs over a period of time, we see that there's a cascade effect that leads to electrolyte loss, and that can become so severe that patients arrive with a hyperosmolar coma, which can be life-threatening. So what do we know about the clinical manifestations? Often they can be very nonspecific. Sometimes we see patients with type 2 diabetes at time of onset to have classic symptoms of type 1, but often not. We are much more likely to see them report fatigue, recurrent infections, and in particular yeast infections. Yeast loves sugar. It loves that high level of glucose, so we'll see often recurrent yeast infections, and that can be a vaginal or perineal yeast infection. You can see yeast infections in skin folds and other places. Prolonged wound healing is another area of concern when it's taking a long time. Again, the wound is not able to heal well when you have those high levels of glucose, and pathogens are supported by that environment. And then finally, visual changes. So how do we diagnose type 2 and type 1 diabetes? Four methods are important to keep in mind. One is the A1C, and A1C measures the amount of glycosylated hemoglobin. That's a percentage of your total hemoglobin. So if we had an A1C of 7%, that means 7% of the total hemoglobin has glucose attached to it. And what we want to see is an A1C less than 6.5. The important thing with an A1C is that gives the amount, it gives you an overall range that reflects the last 120 days, so about the last 4 months. We can do a fasting plasma glucose test, and that's often done once and then confirmed or repeated on a second day, and that's the preferred method. When an oral glucose, 2-hour oral glucose test is conducted, a patient is asked to drink a dose of glucose, and typically it's about 75 grams. And that we do a blood sugar prior and a blood sugar post, and we see the range of blood sugar. So if 2 hours after drinking that oral glucose tolerance fluid, that 75 grams, the patient's blood sugar is greater than or equal to 11.1, that would be diagnostic. And we can also do a random glucose measurement, again, greater than or equal to 11.1, plus symptoms would also be diagnostic. So what are our goals when we're looking at the care of patients who are experiencing diabetes? First of all, we want to really recognize what are the symptoms the patient is experiencing and how we can reduce those symptoms. And most of all of these things, this for sure is related to being able to bring blood sugar down to within a reasonable level, certainly to within normal. Sometimes diabetics will have an ideal range that might be slightly above normal. We want them not to be so tightly controlled. If we say you have to bring your blood sugar to just between 4 and 6, that can be very difficult range, and they can be fluctuating constantly sort of below the 4 and be at risk for hypoglycemia. So we want to decrease the symptoms that they're experiencing associated with their diabetes. That could be fluctuations in blood sugar that would be symptomatic. That could be wound healing issues. That could be, again, that overgrowth of yeast. It could be cardiac symptoms and other things. So decreasing those associated symptoms. We want to promote their well-being, physical, psychological. It doesn't feel good to have either a high blood sugar or a low blood sugar. So that well-being and experience of life in a positive way. We want to prevent those acute complications. Remember, we said they're twice as likely to die prematurely when you have diabetes as if you don't have diabetes. So the more we can control your diabetes, manage your diabetes in an effective way, the more likely you are to prevent some of those acute complications, often thinking about cardiac complications, as well as infection and other kinds of things. Eye damage is another important one we want to consider, and delay in onset the progression of long-term complications. That often happens at target organs, so your eyes would be one, your kidneys would be one, so renal failure, development of ulcers, and other things as you have poor circulatory flow through the capillaries. Oh, yay. Let's do a question. We have a client screened for diabetes at a clinic, fasting blood sugar 6.7. What should the nurse explain about this finding? 1, is it diagnostic for diabetes? 2, it's normal and diabetes isn't a problem. 3, it reflects impaired glucose tolerance, which is an early stage of diabetes. Or 4, it indicates an intermediate stage between normal glucose use and diabetes. And I know you all know the answer is 3 because we're talking about prediabetes. So now when we're talking about collaborative care, it's really important that we move to a model where self-monitoring of blood glucose is critical. Self-care for the diabetic patient is really critical. In the old days, we used to think of prescribing a diet for patients with diabetes, prescribing a certain number of carbs, and the patients had to follow that, and then they had a static insulin dose. We've moved so far away from that. They may have relatively static basic doses and then modulate that depending on oral intake with short-acting insulin. More and more we've moved to the carb counting method in nutritional therapy so that patients are not restricted so much in what they can eat, but rather are able to calculate the insulin requirement based on the carbohydrates that they are ingesting. So important that we work with clients so that they are able to manage their diabetes in such a way that their life doesn't feel like it's being overtaken by insulin or oral glucose lowering agents, and their quality of life can be so deeply impacted by feeling that they have no control over their own life. Finally, really important that we focus on exercise, the impact of exercise, the wellness associated with it, but also your insulin needs and your blood sugar fluctuations associated with exercise. Let's talk about insulin for a second, although I know you know it. Exogenous insulin just means it's not the insulin you're making in your own body, but it comes from outside. Type 1 diabetics for sure require exogenous insulin because remember, their pancreas has stopped making it. Patients with type 2 diabetes who can't control their blood glucose by any other means, so with oral agents, may have to start using insulin as well. So when I was a nursing student, we used to talk about all these other kinds of insulin, pork and blah, blah, blah. But now all insulin is human insulin. So it's all human-based insulin, and that's prepared through a genetic engineering process. And there's a variety of insulins. They differ with respect to their onset, their peak action, and their duration. So we look at typically rapid acting, short acting, intermediate acting, and long acting. And often it's not just one kind of insulin we take, but it's a combination of a variety of insulins. We want to neither heat nor freeze it. We want to keep it in a vial that it comes in. It can be stored at room temperature for up to 4 weeks. If we have extra vials of insulin, they go in the fridge. We don't want to expose them to sunlight, but if you've got it on your, your bedside table or your counter, it's not that it's going to degenerate immediately. It's important that we use various combinations of insulin to help to tailor treatment. Remember, we said it's so important that the patient has some control over their life and their eating habits and other things. So when a patient is able to identify their own pattern of blood glucose levels, and look at their lifestyle, their eating, their activity patterns, then they're able to tailor their insulin intake with that as well. So let's talk about the kinds of insulin just for a second. We've got rapid acting insulin, and there's a couple of types. We've got Lispro, which is Humalog, and you see that a lot. Aspart or Novorapid, and Glucosine or Apidra. And with those, typically we give like right before a meal, like right as the meal is arriving, or up to 15 minutes before a meal. That onset of action is about 15 minutes. And so that's why we want to take it 0 to 15 minutes ahead of time. We've got short-acting insulin, and that's our regular insulin. Keep in mind, regular insulin is also the only kind of insulin that we give intravenously. Regular insulin can be given 30 to maybe 45 minutes before a meal, and the action of onset is about 30 to 60 minutes. So 30 to 45 minutes before a meal, we'll be giving that. We've got intermediate acting is the NPH. Long-acting insulin is actually given once a day at bedtime, and it's released steadily, continuous. We typically aren't looking at a peak action, but it's important to recognize that that long-acting insulin cannot be mixed with any other insulin solutions. When we're injecting insulin, there's a variety of sites, and I think that's maybe on the next slide or 2 slides from now. But the fastest absorption of insulin is from our abdomen, followed by our arm, our thigh, our buttock. I have never seen anybody self-inject insulin into their buttocks, but maybe you have. I would let patients know if I was doing teaching that that's a possibility if they've used up all of their other sites, but really I don't know anyone who's done it. Abdomen is really the preferred site because it's well absorbed. We want to rotate our injections within even the site. So even within your abdomen, you're going to rotate the site of your injection. And if we're going to be exercising, we don't want to inject into that site, right? We don't, because you're going to have a rapid movement of that insulin into your bloodstream. And in your textbook, it's one of the tables, I think it's 52.5. It talks about subcutaneous insulin injections. So here are the sites, and we just talked about those. So insulin typically comes in 100 units per mil. We use an insulin syringe. We don't use any other kind of syringe. We don't need to use an alcohol swab on the site before injection, which is very different from most other injections. We're going to teach our clients to wash their hands with soap and water, but nobody needs to wear gloves. Again, clients don't recap that needle even at home. We give them a sharps container. Insulin subcutaneously is administered at a 45 to a 90-degree angle, depending on how thick the fat pad is that we're injecting into. And if we've got an insulin pen preloaded with insulin, we would follow the directions for that. Oh my gosh, look at how beautiful that is. That insulin pump that gives us so much control over our regulation of our system. So in an insulin pump, what we have is that continuous subcutaneous infusion. It's battery operated. It's connected via little plastic tubing to a catheter, and then that's inserted into subcutaneous tissue. And we are really able to have much tighter glucose control with that insulin pump. So what are some complications associated with insulin therapy? Certainly one would be hypoglycemia. So low blood sugar, we've given too much insulin, we've overshot our mark, we thought we'd had more carbohydrates than we did, or we thought our blood sugar was different than it was. We gave our insulin without doing an AccuCheck or a glucometer reading. Lots of reasons that might happen, but in giving insulin, one of the biggest and most concerning possible effects is that hypoglycemia or a low blood sugar. You can also have local allergic reactions. Those can be self-limiting, maybe 1 to 3 months or so, and we can improve those with some antihistamine. Lipodystrophy, so that fat becomes impacted by that continuous injection, and it can become mottled and bumpy and lumpy and become not effective for future injections. Interesting when we look at the dawn phenomena and the Somogy effect. So the dawn phenomena happens when there's a rise in early morning blood sugar levels, and those are triggered by declining levels of insulin and an increase in growth hormone that happens in the morning. So dawn phenomena, we have early morning high blood sugar levels. Those are triggered by, again, a lower insulin levels. Let's say we've given our insulin in the evening and it's peaked and now it's declining into the morning, and also our growth hormone is increasing. But we also have the Somogy effect, and that's seen in people with diabetes who use insulin to manage their condition. And that's caused, interestingly, by taking too much insulin or not eating enough before bedtime. During the night, in the Somogy effect, during the night our blood sugar drops, our body responds by trying to kick in all of its adaptive responses, and our blood sugar comes up. So in the Somogy effect, we also see a rise, a morning rise in blood sugar, but it often is because we have had a low in the night without realizing it, and then our body is responding by bringing it back up. So oral drug therapy, so that's not insulin. Insulin is only injectable, either subcutaneously or intravenously in emergency situations, or in situations where a patient is unstable. When we're talking about oral agents, those are, again, typically for type 2 diabetes, and they work on those three elements: that insulin resistance, that decrease in insulin production, and that increase in hepatic glucose production. So all of those things can be mitigated through the use of oral hypoglycemic agents. So there's different agents that we can use, and I'll give you some examples. So we've got sulfonylureas, and drugs that you might have heard there would be gliclazide, glyburide, and other ones. Those increase our insulin production. Glimepiride, that's another one I think that increase our insulin production. When we think of the meglitinides, those would include things like gluconorm, which is repaglinide, sorry about that, and netaglinidine, which is also called Starlex. Those increase insulin from our pancreas. Okay, so they increase insulin at the level of our pancreas. Another really common one that you see is metformin or glucophage. And that is the third category, which is a biguanide, and that is a glucose lowering agent. So that what that one does is it works at the level of your liver, and it reduces your glucose in your liver. We also see that there is those alpha glucosidase inhibitors are starch blockers. And then finally, we have medications that improve our insulin sensitivity. And a really common one is Avandia. We see those ads now for including that into with a multi-drug regimen for type 2 diabetes. So when we're talking about nutritional therapy in particular for type 2 diabetes and for type 1 diabetes, when we're talking about managing carbohydrate intake with insulin use, nutritional therapy is just absolutely the cornerstone for working with clients in their increasing their control of their diabetes and their self-management. But it's also hard because it's this control, almost feeling like an over control, or feeling as though you are powerless and being regimented in a way that can be very hard in terms of lifestyle. So important that we have a diabetes nurse educator and a registered dietitian who specializes in diabetes to work with your clients, and also to work with the team. With the CDA, or the Canadian Diabetes Association, they provide tons of information, a variety of teaching tools specifically focused on nutrition that are geared both to patients but also to healthcare providers, and all of that is free of charge, and again, it talks about it in your textbook. So let's talk about the difference in nutritional therapy for type 1 or type 2 diabetes. Type 1, you might give them a meal plan. We're moving away from this, right? But we look at their individual food intake, and then you balance that with insulin and also exercise. And your insulin regimen is managed day to day, meal by meal. In type 2 diabetes, we really want to focus on achieving their glucose, lipid, and blood pressure goals. So we look at that sort of over the long term, as opposed to that tight control that has to happen meal by meal. But with type 2 diabetes, remember, we have that buildup of fat, and patients often present overweight, and we want to really focus on sort of calorie reductions to eating within a normal range of calorie for lifestyle and other factors. Now, what's the glycemic index? It's interesting. When we think of a glycemic index number of, for example, 100, that refers to the response of 50 grams of glucose to white bread in a normal person without diabetes. And so all other foods on that glycemic index are then measured against that standard. And so it's looking at the effect of whatever food it is in terms of its carbohydrate value and the impact on your blood glucose levels. So an apple has a glycemic index of 52. Milk has a glycemic index of 27. A baked potato might have a glycemic index just over 90, and you can just look those up. Let's go on with nutritional therapy. Usually this is a specialized kind of teaching, and you're going to have a dietitian involved in this. We do carb counting now, as opposed to just putting someone on a regulated meal plan, so then people can manage their lives in ways that are consistent with them. Canada's Food Guide continues to be an appropriate tool, although there is some politics associated with that. And there was also the new release of Canada's Food Guide last year, which was not without controversy. But the bottom line is, for your NCLEX, you're going to say Canada's Food Guide would be an appropriate teaching tool. And for your own life and your patients, you're going to have an open mind to see where we go with this. And there's something that we use called the plate method, where we help patients to visualize what food would look like on a 9-inch plate, and how much vegetable starch and meat should fill it. So for example, when we're looking at that plate, about half of it should be filled with the non-starchy vegetables. About a quarter is filled with starch, so potatoes or sweet potato or something, or some pasta, something like that. And about another quarter is filled with protein, whether that's plant-based or animal-based. Oh my goodness, now we're on to exercise. In diabetes management, it's so important that we work with our clients to have an active and healthy lifestyle. People with diabetes should perform at least 150 minutes per week of moderate intensity aerobics, and also resistance training about 3 times a week in the absence of other kinds of contradictions that like cardiac conditions, things like that. Exercise is important because it increases insulin receptor sites. Exercise is going to help us to lower our blood glucose levels and also contributes to that goal of weight loss. So how do we manage that? We're going to make sure that during exercise, patients with diabetes are able to have an opportunity to have some small carbohydrate-based snacks about every 30 minutes so we don't end up with hypoglycemia. It's best to exercise not immediately after a meal, but shortly after a meal so that, again, we're resisting the likelihood of developing a hypoglycemia. And it's always important that we have medical clearance for exercise and that we have an exercise plan where there is a slow progression. Clients are urged to monitor their blood glucose before, during, and after exercise, whether this is the first time you're exercising or you've been in a regular routine, because lots of things can change with your general health. Also important to recognize, though, that patients are not going to be measuring their glucose 20 times a day. Now, we've moved to systems where patients are actually able to wear a device that enables them to read their blood glucose at any point through their smartphone or other device. That makes it a lot easier. Otherwise, it is a high bar to ask patients to check their blood sugar before, during, and after every time they exercise. And you're likely to need to move with patients to a better way to monitor themselves. And again, that might be with continuous monitoring. So here we go, monitoring glucose, and this is what we were just talking about. Having control within the hands of our patients is really our goal here. So we want patients to be able to make their own decisions about self-management, looking at their diet, their exercise, and what kind of medications they're going to be taking. Here's an example of a blood glucose monitor. There's one, an AccuCheck, which is an old company. It's used to measure those blood glucose levels. And also we see that Freestyle Libre sensor, and that is highly effective in continuous monitoring, right? That's effective not only because it tells us our values, can be updated every 1 to 5 minutes, but also that really gives us insight into patterns or trends. And in tracking those patterns, we're really able to make good choices about how to manage day-to-day diabetes. When we're assessing our patients, we want to look at symptoms that may be associated with hyper and hypoglycemia, but in particular, we're going to check for malaise, for weight loss, thirst and hungry. Those are thirst, hunger, poor healing, all associated with hyperglycemia. Kussmaul's respirations, which are those really rapid, deep breathing that's associated with blowing off those ketone bodies when we're moving into a situation of diabetic ketoacidosis. Constipation or diarrhea that can impact our blood sugar levels. When we see that muscle weakness or fatigue, again, really critical that we're looking at blood sugar levels. For men, it's interesting that we see erectile dysfunction. For women, we see chronic vaginal infections, particularly yeast infections, a decrease in libido. We see depression, irritability, and apathy, also really important indicators that something is amiss in a client's overall state of wellness. Okay, let's look at a knowledge check again. Which statement is the goal of client diabetes education? Is it to make all clients responsible for the management of their disease? Is it to involve the client's family and significant others in their care? Is it to enable the client to become the most active participant in the management of diabetes? Or is it to provide the client with as much information as soon as possible to prevent complications? And I know you all know the answer, which is 3, enable the client to become the most active participant in management of their own diabetes. So when we're looking at that, overall goals is that the client's an active participant. We're going to watch for few to no episodes of acute hyper or high blood sugar or hypo or low blood sugar. We want to maintain normal blood glucose levels, and the range is typically set out. While we know 4 to 6 is the normal range, For a non-person without diabetes, we want to make sure that the range for a person with diabetes falls within what is prescribed by their endocrinologist, and often that is 4 to 7 as opposed to 4 to 6. But again, that doesn't mean that the normal has changed. It's just that maintaining very, very tight control of diabetes can have its own complications. So the endocrinologist works with each of their patients. Overall goals, what we want to do is prevent or delay those chronic complications, cardiac complications, end organ complications, kidney disease, blindness, high blood pressure, cardiac disease, other things. We also want to help them to make those lifestyle adjustments in a way that is not particularly stressful or threatening, but rather becomes overall life enhancing. So we're talking still about when do we need acute intervention? What is the situation in which we find ourselves requiring acute intervention? If somebody is not managing their diabetes effectively, if their blood sugar is acutely high or acutely low. When we look at stress associated with illness or injury, so having a viral illness, having a minor surgery or even a major surgery, our human stress response is to increase our blood glucose level. If you think of that fight or flight, a physiological stress response is to make glucose available should I have to do something. And so we want to watch that glucose levels can go up. In that state, we want to continue with our regular meal plan, increase our intake of fluids, not necessarily, not fluids that have more sugar in them, but non-caloric fluids. So that could be, best is water, could be sugar-free beverages like sugar-free sodas. It could be clear tea or other things. So we want to increase our fluid intake. If you're taking your oral agents or insulin, we want to continue to take those and watch for frequent monitoring. So unless our blood sugar goes above 14, we're not going to have to look for ketone testing. But once we hit 14, we're going to have to be cautious of that. But recognizing that a temporary rise in blood sugar associated with acute illness, an injury, a surgery, they may invoke that sort of counter-regulatory hormone response, and they can cause hyperglycemia. But we're not. It's important that we don't over-respond to that, right? So we don't suddenly, because someone's blood sugar is a little bit high, we don't give them insulin and they become hypoglycemic. We want to actually treat the underlying cause. We want to make sure they continue to eat or drink if they can, and that we want to increase their fluid intake. It's really important that when we look at patients who are undergoing surgery or specific radiological procedures, if they require contrast medium, that they hold their metformin on the day of that procedure, on the day of their surgery, and for 48 hours. And it's really important that we check their serum creatinine and make sure that it's normal. Also, keeping in mind that if we're caring for unconscious surgical patients who are getting insulin, we need to watch for signs of hypoglycemia where a person's not able to talk to us. So we'll see things like sweating, tachycardia, tremors. So keeping in mind when patients are experiencing illness or undergoing surgery, there are some changes to their daily medication regimen, in particular with metformin, because of the challenges associated with the contraindications. And also when a patient is undergoing a procedure, they may not be able to talk to us and explain how they're feeling. So we're going to watch for those physiological signs of hypoglycemia instead. And then finally, just a picture here for all of you that we see a medical alert bracelet. It's so critical that patients have something to show that they are a diabetic, in case they're not able to tell us that verbally. And often we have a travel card as well as a medical alert bracelet. Here's an example of somebody who's got a tattoo as well. That's it for this one, and we've covered diabetes. There's a lecture on acute and chronic consequences, and there's also the lecture on thyroid conditions. So we've covered all of our endocrine conditions, and I'll talk to you soon.